if our colleague from New Image could start the live stream, please, in 5, 4, 3, 2, 1. Thank you. Right, Chair.
Okay, so good afternoon and welcome to this virtual meeting of the Health and Wellbeing Board. I am Councillor Jean Stretton and I will be chairing the meeting. Regulations have temporarily removed the legal requirement for local authorities to hold public meetings in person. However, the requirement for public meetings to be accessible to the public remains, and the link to this virtual meeting is available on the Council's website on the Live Meetings link page. If a connection to a member is lost during this meeting, I will stop the meeting to enable the connection to be restored. If the connection cannot be restored within a reasonable time, the meeting will proceed, but the member who was disconnected will not be able to vote on the matter on discussion, as they would not have heard all of the facts. Should any aspect of the external link fail, I may call for a short adjournment of up to 5 minutes or so to determine whether the connection can be quickly re-established, either by video technology or telephone in the alternative. If the connection is not restored within that time, the meeting will be adjourned and any further business will not proceed until another time and date. Before I ask the clerk to take a roll call, may I introduce and welcome to the meeting Donna Césaire, I'm sorry if I've mispronounced that, the recently appointed Chief Officer of First Choice Homes. Thank you. Can I now ask the clerk to ask the members and our standing invitees to confirm their attendance?
Councillor Cathball. Mike Barker. Councillor Bashforth.
Present.
Donna Césaire, I think will be joining us in a moment or two. Just
okay.
Councillor Chowan. Oh, sorry, Donna Césaire has just joined us. Councillor Chowan. Present. Majid Hussain.
Yes, I'm here.
Gerard Jones.
Present.
Stuart Lockwood.
Present.
Councillor Moores.
Present.
Dr. Patterson.
I'm present. And Donna, just before you arrived, you were very warmly welcomed by us all. So may I just, on behalf of us all, warmly welcome you again.
Thank you. So I just had a moment of difficulty connecting, but thank you. Really pleased to be here.
Katrina Stevens.
Present.
Councillor Sykes.
Present.
Taimur Tariq.
Yeah, present.
Mark Warren.
Present.
Karen Worthington. And Councillor Stretton.
Present. And Councillor Ball did send me a text message earlier to say that
I've just got here, Jean. Thanks.
Oh, right.
maybe Miss she's here.
Yeah.
There you go.
Right, thank you.
Okay. Okay, we also have council officers from Public Health, Policy and Constitutional Services in attendance. While we meet formally as a committee of the council, the board is also a partnership in which we strive for consensus. Where we are required to make decisions, I will try to ensure that we do this by general assent and will only ask for a roll call vote when general assent is not shown. If the board is required to take a vote, each voting member will be individually asked to state whether they are for, against or abstaining. If we can now turn to the agenda, and for the benefit of members of the public watching, the full agenda pack is available on the council's website. Okay, so do we have any apologies for absence?
We have apologies from Dr. Keith Jeffrey, Chief Superintendent Allsop, David Jago, Liz Windsor Welsh, Carolyn Wilkins, Joanne Sloan, Claire Smith and Rebecca Sutcliffe.
Thank you. Okay, so I'm assured we have no items of urgent business. Do any members wish to make a declaration of interest? Okay, I'll take that as a no then. Members,
sorry, Chair, I put my hand up.
Oh, sorry. It's difficult because I can't see both things at once, unfortunately.
So Taimur has got a declaration. Have you, Taimur?
Yeah, okay.
Yeah, through you, Chair. I know there's an item there relating to other parts of Greater Manchester, including Bury. So, personal interests, I'm an elected member in Bury and also a member of the Bury Health and Wellbeing Board.
Back to... Okay, try and get back to the agenda, unfortunately. Right, okay, so do we agree the minutes of the last meeting? I'll take no comment as assent. Okay. Item 5, we have no public questions. Items 6 to 8 are the annual reports of the Child Death Overview Panels and the National Child Mortality Database, which will all be introduced by Rebecca Fletcher and Annie Lowe from the Public Health team. So can we move on to item 6, the Bury, Rochdale and Oldham Child Death Overview Panels? Rebecca.
Hi, thank you very much indeed for having us here. I've got a presentation which I'm going to share, but Annie and I will be presenting different parts of these together. So let me quickly share, and if people can let me know if they can see this. I'm hoping that the technology will work.
Yes, we can see.
People see the report.
Yes.
Brilliant, thank
Yes,
you. I can't see any. Thank you. I can't see anybody's face or hands. So what we'll do is we'll run through the GM bit, then take it down for any questions, and then we'll do the orbit. And then we'll take each of the items in turn. So just to give you a quick overview, this is the annual reports from the child death overview processes that happen. So these child death review processes are national mandated processes where all deaths of children and young people aged under 18 are reviewed. The guidance was updated in 2019 and that was implemented locally. So we came to the Health and Wellbeing Board here last year in order to update from the report then. The process, the Child Death Overview Panel process, which is where these reports have come from, is the final stage in quite a lengthy process where all of those deaths are reviewed. They're initially reviewed within the services where the child has care has been and where the child then has died, and that's a child death review meeting. And then following the result of all of those reviews, including any based within the coroner system, following all of those and the conclusion of those, they finally come through to the Child Death Overview Panel, where then we review them as an entirety. And I'm going to pass over. So we bring together all the information from all of these reviews per year into an annual report, which will help to inform any future work to reduce the likelihood of deaths in these in under 18s. I'm going to move to the Oldham, Rochdale and Bury report. Annie Lowe has pulled this report together and will be presenting it on our behalf. So Annie, if I hand over to you, but if you tell me when you want me to move over the slides, that would be great.
That's great, thanks Rebecca. So hi, my name's Annie. So I will take you through the Oldham, Rochdale and Bury report. Next slide, please. So I'll just start by going through our methods. So Oldham, Rochdale and Bury have a shared child death overview panel, and it's one of 4 panels in Greater Manchester. The annual report that we're presenting today is a review of the closed cases between the 1st of April 2019 and the 31st of March 2020. And we use the closed cases because it's only after this whole process has been complete and the case has been closed that we have enough detail to form a narrative around a child's death and to identify those important themes. So it's important to note that these deaths didn't necessarily occur within this window, and some may have occurred before the 1st of April. The results are mainly explored as a collective area rather than individual local authority, and this is because of the small number of cases and for confidentiality purposes. The report includes a review of the CDOT process, and then the closed cases are explored in terms of general demographics and modifiable risk factors. And then we look at the different interventions that are going on in the 3 localities in order to address these risk factors. This year there were 29 closed cases. This is a few less than normal, but this is a trend that we've seen nationally. So it's felt to be because of changes to the CDOT guidance and the way things work, which has caused an increase in workload. Also in Oldham, the CDOT officer role was vacant for some time, but it has now been filled. Next slide, please. So this slide just summarises some of the main findings from the report. 66% of closed cases in Orb were expected deaths. 69% occurred in hospital settings. We know that children are at highest risk of death in their first year of life, and this is reflected in our data. 34% of closed cases occurred in the neonatal period, so that's within the first 28 days of life, and 58% occurred within the first year of life. So this is what we would expect to see, as perinatal and neonatal events are the most common cause of death nationally. And in Orb and across all 3 localities, this was the leading cause of death. So this pie chart just shows the main causes of death as percentages of all the closed cases. So we can see here the big brown section on the bottom, 35% of deaths were perinatal and neonatal events. The second most common cause was chromosomal, genetic and congenital abnormalities, and these accounted for 18% of the deaths. So when we combine these 2 main causes of death, they equate to over half of our closed cases. It's also important to note that in relation to the chromosomal, genetic and congenital abnormalities, all these cases occurred in children of BAME ethnicity. Now, consanguinity is a known risk factor, but it wasn't actually found to be related to any of these deaths. Also, there were no deaths classified as deliberate or of suicide and self-harm. Next slide, please. So this slide just shows some of the main themes that we can see both nationally and within our local data. So prematurity is a major risk factor for infant mortality, and across Orb, 76% of child deaths under the age of 1 were born prematurely. Now, there's lots of factors that can contribute to prematurity. Some of them are out of our control, but it's also important to note that preterm delivery is associated with risk factors such as deprivation and maternal smoking. There tends to be higher rates of child deaths in males, and this is something that we don't quite understand or know the reason for. In Orb, 62% of closed cases were male. There are higher rates of child deaths in children from deprived families. So in Orb, 31% of cases were in the most deprived 10% of the population, and 79% of cases were in the most deprived half of the population. Ethnicity is also a factor, and there tends to be higher rates of child deaths in children of BAME ethnicity, and this trend was seen in Bury and Oldham. Next slide, please. So a really important part of the report is looking at modifiable risk factors and identifying any areas that we can look at in order to reduce child deaths in our local area. 31% of cases in Orb had modifiable risk factors identified, and in these cases where there was a factor identified, 78% had more than one. So this suggests that there's perhaps a multifactorial element here, that a collection of factors add up together to make a child more vulnerable to child death. So this slide just summarises the 3 main risk factors that we found in the closed cases this year. So first of all, maternal obesity in perinatal and neonatal deaths. This was the most common risk factor identified. So in 18% of closed cases under the age of 1, obesity was felt to be a modifiable risk factor. But in 59% of closed cases under 1, the mother was classified as overweight or obese. So although in these cases this time it wasn't felt to be a risk factor, we can see that it's an increasing concern and may start to become a risk factor in more child deaths. So what are we doing about maternal obesity? Across the localities, health visitors work with expecting mums to promote healthy eating, and Oldham has a new integrated health improvement and weight management service, which takes a family-centred approach, and obesity is one of their main objectives. Second is maternal smoking. Now, maternal smoking during pregnancy is a risk factor for perinatal and neonatal deaths, and this is because it's a risk factor for preterm delivery. So in previous years, maternal smoking was the most commonly identified risk factor, but this year it's been overtaken by maternal obesity. This year it was identified in 10% of cases, but it was felt to be a modifiable risk factor in only 3% of cases. So this perhaps suggests that we're making some improvements in this area. Oldham Hospital use Baby Clear, which is a GM smoke-free pregnancy programme, and it's a midwifery-led service, and the team have recently appointed a new midwife to deliver the service. They're also piloting a scheme where nicotine replacement therapy is given to expecting mums directly from the maternity unit. The hospital also work within Saving Babies' Lives, and this is a national evidence-based care bundle which aims to reduce perinatal mortality. It's been updated to version 2, so the hospital has been working hard to get fully compliant with all the new regulations. The third is risk factors associated with sudden unexpected deaths in infants, and these deaths account for 10% of Orb's closed cases. And in 2/3 of these, there were modifiable risk factors identified. So these risk factors include things like unsafe sleeping, parental smoking, and drug and alcohol use. In terms of interventions, safe sleeping advice is given by midwives and health visitors, and risk assessments with families are done. Next slide, please. So this slide just summarises the report recommendations. The first 2 are mainly relevant to the local CDOPs, so I'll just take you through the last 3, which are important considerations for the Health and Wellbeing Board. So first, we need to be aware that maternal obesity is a growing concern and is a risk factor in perinatal and neonatal deaths, and we need to ensure that work is being done to reduce maternal obesity. Children living in deprived neighbourhoods or who are of BAME ethnicity continue to be overrepresented in child deaths. This is also something that needs to be addressed. The findings of this report should be used to raise awareness for these discrepancies and ensure that work is being done wherever possible to reduce these inequalities. Finally, it is advised that this report is disseminated with relevant departments within the Health and Wellbeing Partnership in order to share learning. Thank you.
Shall I take down the presentation now so that people can ask any questions?
Yeah, I'm done with the presentation, thanks.
Okay, does anybody have any questions?
Yeah, Chair, I've got a question. I don't have. Yeah, thanks.
Yeah,
thanks, Chair.
see,
thanks, colleagues, for the report. Just a quick question around specific actions to tackle the deaths in relation to deprivation and ethnicity. So if you could give us a little flavour of what you've done in previous years, what's worked, and going forward, just a flavour at top level, and what actions you're intending to take to try and reduce that disproportionality.
I'm happy to pick that up, Annie, if that's okay. Thank you for the question, and it's one of the key issues that we don't just see in Oldham, but we're seeing nationally as well. So one of the things that we've been doing is working with our health visiting, in particular midwifery colleagues, around particularly that 0 to 1 and 0 to 5, where we see the highest risks of death, working with them around the place-based approaches so that the interventions that they're providing are relevant to the place that they're based in order to try and address some of those issues. Some of the interconnections between deprivation and BAME and child deaths are difficult for us to understand the evidence base behind, but one of the things we're trying to do is ensure that the services which we know address some of the other risk factors are appropriate and actually accessible to everybody in those areas and work for them within that place-based approach. So I think that's I guess the very top level approach of what we're doing, but I think what's really important is that I think the information around the higher risks in those groups is also disseminated to other areas, not just midwifery and health visiting or your traditional kind of children's services, but the broader system. So that recognition that the risk is broader than that, and I guess that's what part of this report and the dissemination of this report is hoping to do.
Thank you for that. Are there any further questions? I'm not quite sure who's got their hand up. Gerard, yes?
Thank you, Councillor Stretton. Yes, we've seen an increase in quite serious incidents involving under 2s in children's services recently. Some very severe accidents to children that have given them very, if not significant, life-threatening injuries. I think at the end of last week we saw 2 children with fractured skulls who'd been dropped, one down the stairs, one off the bed, which were really accidents, although there was a neglect related issues in those cases. We've seen some quite serious incidents, also children being harmed, very young children. We had a case where a very small child was punched in a domestic violence incident, resulting in an injury. So we are seeing definitely a very significant rise in injuries and concerns for very young babies, related, we think, to pressures of family life in lockdown, where young mums are unable to get the support of their families, crying babies, placing stress on family households, overcrowding. We've seen a number of families that have had to move in with their family members because they've lost their tenancy, causing even higher levels of overcrowding and stress on families in Oldham. So it's just to, I suppose, remind colleagues what we know already, that Oldham has been hardest hit, longest hit in the country through lockdown and through the economic disadvantages and other harms in our community. And we've seen very significant increases of referrals. So 66% increase in serious domestic violence, 39% increase in referrals on last year, and a very significant increase on children on child protection plans. So inevitably, some of this may feed through. I think fortunately none of those children have died, but we see the sorts of harm that that arrives when in our community when families are under a lot of stress and difficulties occur. We've also seen oversleeping issues too, as a result of overcrowding and as a result of families being at home too long. And unable to get the support sometimes they need. So I just wanted to assure you, Councillor Stratton, that's a grim picture I've painted you. We are looking with our colleagues in community paediatrics and our Right Start programme and with the support of Katrina's team and Rebecca to examine how we can improve our offer to those families, to publicise crying, what to do with the crying baby, what to do with when you feel at high risk of domestic abuse, what to do when you feel desperate as a parent with a new baby. So we're looking at strengthening our services and strengthening publicity about our services, but these demands are placing our services under significant pressure, and there is a waiting list, for example, for cases for our intensive support in domestic violence as a result of those demand pressures. So we are at risk of raising awareness but not being able to offer a service. So that's the sort of position we are in Oldham, and I suppose want to say, Councillor Stratton, that not all places in the country have experienced that level of pressure. Not all places in Greater Manchester and in the Northwest have experienced that level of impact and pressure that we have become sadly accustomed to in Oldham. And speaking to colleagues in our school system, we were supporting a school in Cambridgeshire. They'd had no in the last year. They've missed no days at school. They've done their exams normally, and children in early years settings have attended normally. Health visitors have worked normally, and the impact on the health system has been minimal. Whilst we know that in Oldham it's a very, very different picture. And that's the impact that arrives in the health and well-being of our community. So I hope that's helpful, just to share how these concerns arrive in our community.
Thank you, Gerard. Councillor Kath Ball.
Thank you, Chair. It's just a short one. A healthy diet costs much more than a lot of our families can afford. Are we pushing the Healthy Start vouchers, which do help?
Hi, yeah, I'll pick that up. Thank you, Councillor Ball, for that. And I think it's really important. The Healthy Start vouchers, we are working on that and we are pushing them. Thankfully, the ability to how you apply for them has been made easier since the start of the first lockdown. The old system that involved writing a letter and having it signed by a midwife or health visitor caused lots of delays for families and was a real issue. And that has been changed now. So yeah, we are working with that and pushing that. I think it's a lifeline for many families. So yeah, absolutely agree. Thank you.
Thanks.
Councillor Marie Bashworth.
Thank you, Chair. Annie, just want to say that was a really good report. There's a lot of valuable information in there. So you say you're going to share your report with all the relevant departments. So what plans are there to get the messages out to the public? I'm thinking of like GP surgeries, maternity units, where people can actually see starkly in front of them what the highlights, what the bullet points are, if you like, for the health risk for their babies.
Thank you for that question. At the moment, previously, CDOT reports have always just been they're available for the public, but in the current format, which I recognise isn't particularly necessarily friendly to read, and they're usually held on the Safeguarding Partnership website. We use the information from it to inform things like our work around the safe sleeping, work with health visiting, etc. We haven't previously done it around GP, so we're happy to pick that up with our comms colleagues and see whether we can get that out in a way that's more appropriate in those settings. So yeah, happy to pick that up. Thank you.
Okay, so we are asked to note the annual report, and there are a number of recommendations for us to consider on page 38 of the agenda pack or page 28 of the annual report document. Is the board happy to note and accept these recommendations?
Yes.
Happy to know.
Well, I'm not hearing any dissent, so I think we can take that as read. Thank you ever so much. That was a really good report. Okay. Now on to item 7, the Greater Manchester Child Death Overview Panel's Annual Report 2019 to 20. Rebecca.
Yes, you haven't escaped me, sorry. I'm going to quickly reshare. Let me do it from current slide. Hopefully you guys can see this one again.
Yep.
Brilliant. I'm not going to take this in lots of detail because actually the main point is that we find very similar findings across the different levels, but just to give you an overview, the 4 CDOT panels across Greater Manchester, as Annie said, there are 4 of them. We come together as a Greater Manchester network to try and see whether or not at a bigger geography we have more cases and therefore maybe to pick up things that are a bit rarer but might give us a better impression about anything that's going on. So we come together regularly as a network, but in addition we create a Greater Manchester annual report just to pull together all the data. So as you can see, for this, it's the same time period as the report for our local panel. There were 129 child death cases that were reviewed and closed by the CDOPs in that time. Again, in line with our local process, we were seeing a reduction in the numbers that were closed that were able to be fully reviewed, and we think that that is because of the new processes taking time to embed and taking more time to actually deliver. The potentially modifiable factors identified in slightly more once we looked at GM. In 40% of those closed cases, the modifiable factors were identified. Very quickly, and you'll recognise that these are very similar findings. Again, age was a really big factor, and the biggest number of cases were in children under 1. The largest areas of largest causes were medical causes, again in line with our local picture, where we've got perinatal and neonatal sort of factors, the chromosomal abnormalities and other medical reasons. Much less, a smaller number are related to things like trauma or accidents. Again, deprivation and ethnicity, we were seeing higher rates across GM of deaths in those groups, really recognising those health inequalities relating to this. Again, in terms of the modifiable factors, nothing massively different. We absolutely saw the unsafe sleeping in particular came out in this report, relating to babies sharing beds with their parents, babies particularly where those parents have been drinking or have been taking drugs, babies asleep on sofas and other forms of unsafe sleeping. Maternal obesity, again in pregnancy. Consanguinity did come up against in the GM picture, again in relation to those chromosomal genetic and congenital abnormalities. And again, smoking very much in line with our local panel, smoking being still a really key modifiable factors in cases that are closed. The recommendations from this report, again, the first one I think are very much in line with our local one, which is using this information about the higher rates and risks, particularly in our BAME communities, to inform our local work. Second one is around the focus on smoking cessation, making sure we don't lose focus on that, even though we're already doing lots of work. It's such a key piece of work that we can do to reduce risks for babies. Again, around the levels of obesity, and Annie's already highlighted the work that we're doing there locally. One of the key things that did come out, though, is that we've now gathered the information on child death reviews for the past 5 years across Greater Manchester, and it was considered that it would be useful for us to pull all of that together into a whole overview to see whether or not having more data might give us some better insights or more information about what key actions we could be doing locally. So that's a suggestion and recommendation coming out of the report. In addition, as we've highlighted and as Annie highlighted, because of the way that the process works, the CDOT process only reviews deaths after all other parts of the system have finished. So sometimes there can be quite a delay in relation to us reviewing deaths and therefore taking any learning from them. That can be a particular issue for things where we may wish to respond quite quickly. So, for example, it was recognised at GM that in particular deaths from suicide can take an awful long time to be reviewed appropriately because they need to go through the coroner system and other parts of the system. But actually, we may wish to respond quite quickly to those types of deaths because we really want to ensure that we deal with any issues as quickly as possible. I think here I can reassure you that in Oldham, just as in Bury and Rochdale, we have a really good relationship with our coroner, and we have a relationship where she provides us with details on all of the deaths related to suicide or self-harm, and also highlights to us any emerging issues. I just wanted to give that context to there. And then the final recommendation is around implementing an electronic CDOT reporting system. As you've heard, we've seen delays in the system and seen less cases being closed. So we'll be implementing an electronic CDOT system, which will enable anybody who is putting the information together for CDOT to do so much more easily online, and therefore reduce some of those delays. And that's the end of the bits from that report, and I can take down and take any questions on the GM element.
John Patterson, you have your hand up.
Thank you, Chair, and thank you, Annie and Rebecca, for your reports. And of course, this isn't the most pleasant way to spend a early afternoon thinking about the subject, but knowing you all very well and getting to know some of you very well, you know, it's motivating to read that so many of these cases are preventable, that this is not an inevitable consequence of living in a challenging, hard-pressed neighbourhood. And I suppose for me, that's a real important takeaway. I would like to also assure people that we do base our commissioning on this report. So the Baby Clear programme, which I think has been a great success, was based on a conversation about this report that we had several, years ago, when, because this report comes to us regularly. So there are things that are happening. One question, Rebecca, would be that I note that there's no trend analysis and there's no impact analysis. And what I mean is, and I understand the numbers are small, so it might be risky, it might be, so not risky, it might be open to, some fluctuation that's purely statistical. But the fact is that as we try and fix this problem, as we try and commission and plan remedial sort of programs, it would be nice to know if they were having a difference, if we could see the difference. So the Baby Clear programme, I've seen the figures to show that we are definitely seeing an increase in mums who stop smoking, and so therefore a decrease of that risk factor, but we've not yet seen whether that's impacted on our maternal, on the child death report yet. So just a question about maybe in the future, so is it worthwhile having some trend analysis in either the big GM or the smaller cohort of the North East sector? And in terms of the impact of the plans that we make, it would be nice if we could have some assurance or some, direction to go elsewhere if those programs aren't working. Thank you.
Yeah, happy to pick that up. Thanks, John. I think the issue is obviously, particularly for the local panel, the numbers are very, very small and the trends would be difficult. We do have obviously the public health outcomes framework that looks at the rates of infant mortality, which might be able to support us in a broader picture. And I think we might look to then maybe include those figures within our CDOT report to put it into that broader context. The Greater Manchester report, I think the idea of pulling together a 5-year report would enable us to look at trends, and I think that would be really important. So happy for us to take that forward in terms of looking at the GM report so that we can look at that and see if we can get some trends put in there. I think as time goes on, particularly if we, even with the small numbers, if we do see significant change, we can highlight that. It becomes very difficult once you come down to, say, Oldham within our report. The numbers are thankfully very small, but if once we go up to GM, we should be able to look at something that might be useful. So we can pick that up for the 5-year report that hopefully the group will agree that we should take forward.
Okay, so we are asked to note the annual report, and there are a number of recommendations for us to consider on page 56 of the agenda pack or page 18 of the annual report document. Is the board happy to note and to accept the recommendations?
Agreed.
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 Okay, then I'll take that as assent. Okay, so the next item is item 8, the National Child Mortality Database Annual Report 2019 to 20. Rebecca.
I know, sorry, this is, I promised, my final bit on the agenda. Again, current slide. Hopefully we can see that. This is a very, very quick report. And as I'd said, the systems and the processes for the child death reviews nationally changed in 2019. As part of that, in addition, a new national database was brought in where all of the information about each child death needs to be inputted. And this is one of the reasons for the delays in the cases. So the first of these reports has now been released. It's a very sort of stripped back report, and we're hoping that the next report, which will be coming out in the spring, hopefully, will give us more detail in terms of factors and themes that we can actually pick up. But I think just to give you a quick overview, that this covers again the same time period as our reports. Across England, we were looking at 3,347 notifications that had been put in. They'd seen the same issue in terms of cases not being closed, and again, absolutely seeing that higher number in those children under 1, and very similar to our data. The modifiable factors, and I take John's point, which is when we see those modifiable factors, these are places where we could make differences and we can make change. And in the national review, about 31% of them had identified modifiable factors, which is fairly similar to the Oldham picture. When we're looking at those deaths with modifiable factors, where we might be able to make a difference, it is in the world of the sudden and unexpected and unexplained deaths and the deliberate injuries and traumas nationally, where they saw the most deaths, where they had potentially modifiable factors. There was the only things I wanted to pull out from that report. It was just to make sure that you to put our local picture within the national figures, and seeing that we are pretty much in line. We aren't seeing anything that stands out dramatically, but the broader report that will come out later this year hopefully will give us further information. I'll stop sharing, and I'm sure I've probably exhausted all your questions, but hopefully I'm happy to take any further questions on that.
Does anybody have a question? Okay, thank you very much for your 3 reports today. In that case, we're going to move on to item 9, which is the Oldham 6-month plan for COVID. And we have a presentation being introduced by Katrina Stevens, the Director of Public Health. Jonathan Downs is also in attendance for this item. Katrina.
Thanks, Councillor Stretton. I believe Jonathan may have had an incident with a BT engineer cutting his internet cable, so isn't able to join us now this afternoon. But I will. I wasn't planning to kind of take you through the report slide by slide for a number of reasons. Really, it's a very detailed report, and I think importantly detailed, and I wouldn't want to gloss over it too much by only giving the highlights. Also, for those of you who were at the development session, I think that was last month, but it might have been just before Christmas. We went through the GM report there, and we have based the Oldham report on the GM report, but given it an Oldham flavour as well. So I don't want to make you all sit through the same presentation essentially, but to just give you some highlights of the report and its purpose really. So we are now almost a year into this pandemic, and whilst there's lots that's been achieved in terms of how we manage and contain and learn to live with COVID, I think as we've gone into this new year, I think it's becoming increasingly apparent that we still have many months of this pandemic to go, and lots more work to do. So the plan really aims to set out some key principles and overarching themes of the work that we think we need to do over the coming 6 months to continue to ensure that we are in the best place we can be to respond to COVID, but also to really recognise and as much as possible mitigate the impact on our population, recognising that COVID has had a substantially greater impact in Oldham and in other areas where there are high levels of deprivation, high levels of inequality. And so there is a substantial element of the report that does aim to focus on those specific issues. In terms of the key things covered then, the report covers what impact we have seen of COVID in the last year. It looks at what are the measures we are going to put in place in our continued efforts to contain the spread of the virus, and how we will understand where we are on that journey. It looks as well at how we will communicate and engage with and activate our communities, because it's with the whole response to the pandemic, it's so important that we take our communities with us and work alongside them. We can only do this in partnership and with everyone's consent. Also importantly, there is a great deal of content in the report looking at how we do mitigate the harms, particularly those impacts that relate to inequality, be that on the basis of income and financial resources, ethnicity, age, or other inequalities. We all know those have meant that the impact of this have been greater for some parts of our population more than others. And then finally, to look at how we continue to live with COVID, so those important elements of test, trace, isolate, but now encouragingly vaccination as well, which is a big part of our strategy as we move forward. So our intent for the next 6 months really is to look at how we make sure we keep the virus at the lowest possible level, and prevent those spikes in infection that were a feature of what we saw last year. We also want to ensure that we are both tackling the harms caused by COVID as well as the measures that are needed to contain it, recognising that there is harm, a great deal of harm associated with doing nothing, but equally those measures that are put in place aren't without their negative impacts as well. Engaging and activating our communities, as I said, is really essential, ensuring that we are seeking to minimise and overcome those barriers to adherence with rules and regulations, that we can minimise transmission and we can improve the resilience and health and wellbeing of the population. Protecting children and young people, I think, is increasing. It has always been important through this pandemic, but as we are now amidst another year where we see schools being closed to all but a smaller number of children and young people, impact on exams, and we know that closing schools will have significant public health, education and other impacts for our children and young people in the long term. So really important area of mitigation in terms of those impacts. And with the tools that we have in the box, test, trace, isolate, vaccinate, we need to ensure that we are delivering those programs effectively into the benefits of our whole population. There is learning that we can draw from what we've seen over recent months. So I think importantly, we know that this has been an ever-changing pandemic, and as things move along, it can be challenging to move with the times, assess the impact and efficacy of interventions, and I think we have got to continue to be fleet of foot and adapt and change with a changing evidence base. Also recognising that there is no one solution to this. We are going to continue to need a package of different measures that all come together, each contributing a small amount to reducing transmission and keeping everyone safe. I think one of the other pieces of learning when we look at what's happened in England, across the wider UK and around the world, is that the earlier and stronger we act when we start to see increases in rates and in transmission, the shorter time those more stringent restrictions need to be in place for. So when we look internationally, we can see that those countries that acted early seem to have been able to get on top of this and to contain it better than in some other countries where where people have waited longer to act, because we know that once rates start to rise, they can very quickly get to a point where they rise exponentially, and then it takes longer for them to come back down again as well. Similarly, I think we saw coming out of the first lockdown in the summer that that restrictions were released in fairly quick succession, one after another. And what we ideally want to do is look at how we can release things one at a time to make sure that we can see the impact of each change and understand it and know when we're reaching the limits of what can be contained in terms of transmission. I think that is increasingly important now with the new variant that does seem to spread much more quickly. And similarly as well, I think when we came out of the first lockdown, we have all the data now that shows us that infection rates were much higher in Oldham and indeed more widely in the northwest than in some other parts of the country, and I think that did impact on what we saw in the summer when our rates were much higher up the table, in fact top of the table nationally. Test, trace and isolate is an important measure, but it has its greatest potential when the number of cases is lowest, and so really important that we keep case numbers low to maximise the potential of that as an intervention. Really important that we keep being led by the data and what it's telling us about where we act and where we focus our attention, focus our resources, but also recognising that actually we have a population in this country that is pretty mobile, and so that we do often have to act on a broad geography. It can be very difficult to contain things within a very, very small area. So I think looking ahead, those key themes that I mentioned at the start around communications, enforcement, compliance, test, trace and isolate, continued engagement alongside support for businesses and the vaccination programme do mean that we have got a whole range of tools in the box that we, I think, know more about how to use and how to implement as we move forward. But it is likely that the situation will continue to change. We know that there are significant challenges ahead. We are in the eye of the storm, if you like, at the moment in terms of the pressure from high rates in that period immediately after Christmas, significant pressure on health and care services and the wider public services, particularly because this is the time of year when those services are under intense pressure anyway. I think as well, there is an element that we have been in this for a long while, and we need to keep people with us in terms of these ongoing changes, keep people's confidence in what we are doing, and that their individual actions will make a difference, because it will only be by those collective efforts that we get on top of this. So, like I said, I've not attempted to run through the report page by page, but very happy to take any questions, and also to just acknowledge that this has very much been a team effort pulling this together. So there are a number of people both in this call who have had a big part to play in this. And similarly, Jonathan's not made it onto the call, but Jonathan has done a sterling job of pulling all the various different elements together, and Rebecca Sutcliffe has overseen the whole process. So just to acknowledge everyone's contributions really to the report. You're on mute, Councillor
You're on
Stratton.
mute, Chair.
Sorry, Dr. John Patterson.
Thanks very much, Chair, and thanks very much, Katrina. Not so much questions as just three very quick comments, if I may. First of all, just to add my thanks, as you've done to the teams who have put this report together. I do like that increasingly Oldham is a place that has a plan, and so and we're all coming together and sharing our expertise. So thank you to all the people that you've named, Mike as well at the CCG, and the various teams that speak up to Rebecca and you and Mike, and in particular Jonathan's sterling work. And I suppose my first then point is that although it's 44 pages, we couldn't capture everyone's contribution in the middle of this pandemic, and so looking at partners around this this table, Donna, Stuart, Tamor, key partners to the endeavour. This is not a sealed box of a plan. This is an agile, adaptive plan, and you are welcome to contribute and to write your chapters and to get involved. The second point I would like to make is that I'm really pleased how we have concentrated on the non-COVID effects and the unintended consequences in this plan as well. We are all in the same storm in this country, but we are not all in the same boat. And as Gerard's story from a few minutes ago, Chair, reminded us, there are other communities who are managing to keep their kids at school, who are undoubtedly managing to keep employment and do other things that are not available to us here in Oldham. And we must be mindful of the long-term consequences on housing, on education, on employment, even on non-COVID health. The gym classes that haven't been attended, the diabetic checks that have been missed. We must be really mindful of that in Oldham as much as we have been anywhere. So, and then the last thing is that the last thing is that as you say, we have to be very agile about this because this is a slippery virus, and it has surprised us in lots of unpleasant ways. And I think one of the things we need to do when we make plans is to come back publicly and say how those plans are going and how those plans have understandably been changed. So, Chair, I would be grateful if we would have a chance to review this plan and to present progress on this plan over the coming year. Thank you very much.
Thank you, John. I think that's a good suggestion. Are we all happy with that? Can we note the report? Okay, so Mike, I don't think you were here when I said that my computer told me about an hour ago that it was going to kick me out. So if I disappear whilst you're making your presentation, it's nothing personal. Okay, so item 10 is an update on NHS developments and their impacts, and we have a presentation from Mike Barker. And if I'm kicked out, I'll get back as quickly as I can.
I would never take it personal, Councillor Stratton. And I know there's nothing worse at 3 o'clock in the afternoon than someone like me comes along with a slide deck of about 50 slides to get through. I'm really sorry, but I will. It's not 50 slides. I'll try and get through them as quick as I can. Katrina's done a sterling job in summarising her part, and there's probably only really two messages that I really want to kind of focus on in this session when I put the actual right slides up. And they are broadly, what are we going to be doing in practical terms for the next 6 months, and what are we looking to achieve from a transitional point of view as we move into this next phase. So I'll be reasonably quick about the first bit. So we still have 1 quarter left of this financial year, and I was reminding myself this morning that we are about 330 days into the pandemic. It was the 23rd of March, the first call I really started to get involved last year. I'm not entirely sure. I thought I'd still be in this place at this point in time, but here we are. And our task remains focused on 5 primary things. One is responding to the COVID demand, including the vaccination programme and maximising capacity. But we've also got to think about how we respond to non-COVID patients in this period of time as well, particularly as we enter into winter and manage the usual pressures. I don't think I've ever seen more of my colleagues looking tired and worn out and increasingly in need of a break, and the health and well-being of our workforce undoubtedly is going to become more important over this period of time. And without being political about any of the next statement, we're still having to deal with the exit from the European Union, and that in itself creates quite a lot of work which people don't really see behind the scenes, that all has to be finished off. So the constant assurance processes around making sure we've got the right supply of medicines to be able to give to patients is an ongoing daily reporting pressure for us. So we're focused through the rest of this quarter on making sure that we adhere to all of the national requests set for us by the NHS, and the focus of those is broadly on 5 things, with an additional thing around Brexit. I wasn't going to go into the detail because the presentation and the papers that have been sent out today lay out what the detail of those actions are, but they're broadly making sure that patients get the right treatment in the right places at the right time as much as we can, whilst also dealing with a pandemic, and that's becoming increasingly more challenging as we go through this period of time in particular. But as you've just heard from Katrina, we some time ago, just before Christmas, started to set out what our plan for the next 6 months would look like across Oldham and its health and care system, and that was part of the overall general recovery strategy for the borough. And we knew full well that from some national guidance that we'd had on the 23rd of December that there would be a continuing need to look at elective recovery during 21-22. There would be a continuing need to think about the investment going into primary and community services as the need for them gets greater, along with mental health. And there will be a renewed focus by the NHS in 21-22, with systems expected to make progress against tackling health inequalities. People and workforce remain important through the next financial year, and integrating care essentially the same. And we've distilled those 6 issues from the centre into 8 priorities for Oldham, particularly. Something quite significant about cancer, elective work, workforce, mental health and learning disabilities, health inequalities, primary care, winter and integrated care. And I think I came to this committee before Christmas and talked about integrated care and where the system was going. The papers that came out lay out a series of what are the actions that we will be taking over the next 6 months in each of those 8 priority areas, alongside what are we already doing as we sit here now and today. And I wasn't going to go through those in detail, Chair. I was going to simply gloss over those and focus a little bit more on this part of the presentation today. So in the middle of managing a global pandemic, reconfigured pretty much most parts of the NHS in Oldham over the past 10 months, we're also now facing yet another reorganisation of how things work in the NHS, and that will largely involve consolidating clinical commissioning groups and the commissioning functions into systems. The system will be at Greater Manchester level, and we're now having to work through, so what will that mean and how will that work? But broadly, our expectation is that from a devolved system such as Greater Manchester, the money flow from the centre will come in at a Greater Manchester level, and we'll set some of the priorities at a Greater Manchester level, but they will very much be part of the embodiment of the 10 localities in much the same way as the GMCA works. And this part of the presentation is aimed to try and just lay some of the foundations for the work that we're currently doing over the next 3 months to start with, and then it'll bridge us to where we get to by the end of March 2022. So I set out to the CCG governing body about 2 weeks ago what I now consider to be 3 phases to our work, with the context of integrating arrangements being stepped up in depth and breadth. The first phase is very much around planning, which is broadly do as much work as we can now to prepare for the future. The second phase is transitional phase, and that from April is about trying to move to some of the new integrated arrangements wherever it's feasible to do so. And then from September through the rest of the financial year, can we start to operate some of the new parts of the system in anticipation of a new operating model from the 1st of April next year. I think we've done a lot of work across Greater Manchester, and I think there's now quite a strong level of coherence. The vision for this next phase of the Greater Manchester Health and Care Working needs to very much be around place-based approaches that deliver better prosperity, health and wellbeing and raise life expectancy, but also to make sure that place-based working tackles the social determinants of health, reduce inequalities, provide high quality proactive care within a population health approach, and focus on people and people we serve and places they live through partnerships. We've equally now started to set out a series of principles to help frame some of the design work that we are now getting on with and starting, which is very much around organising ourselves around local populations and having clear accountability mechanisms in place. Not moving away from the GM system, but strengthening the GM system of having political, clinical and managerial focused engagement and working around the populations. And I don't want to underestimate that, and I'm pretty certain that my colleague Councillor Chohan, who also sits on the Joint Commissioning Board at Greater Manchester, will have something to say about that himself. How do we join things up far better in places, including budget and workforce, and empower communities for change around health and care? And that will now start to mean that we need to think very much about the governance in local places. And I think there's quite a common level of agreement that we need to build on the excellent work of things like health and wellbeing boards, commissioning partnership boards, local care organisation boards, and start to develop a kind of single place-based system board that has oversight of setting the strategy, the objectives, the outcomes for each place in terms of health and joined up health and care, and having aligned political, clinical and managerial leadership accountable for that public health type approach. And there's an awful lot of work now that will need to be done to oversee and design that, both at an Oldham level and at a Greater Manchester level. That of course is one focus on what we broadly describe as the new type of approach to commissioning, and we've also got to make sure that we've got in place the confirmed scope of the delivery model for the future. And some of my colleagues across Greater Manchester would describe that as the next generation local care organisation. I'd probably describe that as Oldham's integrated care vehicle, something that we need to start thinking about and moving forward over these next 14 months, and certainly making some moves towards over the next 3 to get us to the 1st of April with some ability to run some of this new type of working in a slightly different way. The good news around that all sounds very complicated, but I think the good news is we've been doing a lot of this work because COVID brought us together in a different way, and I think this is much more about how do we systematise the learning from that work and take it forward into a proper governed way of working for the future. Equally, we need to really start thinking about, as the clinical commissioning group starts to consolidate to a GM level and I think deploys functions, resources and budgets back down to a place-based way of working, how do we bring together those people that would be working in CCGs with councils and with other parts of the health service into a consolidated single support function that starts to realise benefits and enables us to deploy resources to communities in a way that we've never really been able to do. I think we'll start to see the erosion of the NHS payment by results financial regime and a move much more towards a place-based system budget where organisations that are responsible in each of the localities start to take shared responsibility for financial sustainability. And if you think about what that means for Oldham, our financial planning gap for 21-22 is circa £90 million on a £900 million collective budget. I think there's something quite powerful in the whole system owning the solution and the ideas that will be needed to close that planned deficit as we move into this place. So this will become a much more important way of working, and one in which I think I certainly recognise and welcome as being a much better way forward rather than the conflicting antagonistic approach between commissioning and provision. But all that said, the one thing about Oldham that I think is quite unique is that we have an extremely plural delivery market, and I think this next phase of our working will need to start thinking very clearly about the implications of plurality and starting to help us get much more into a space of collaboration instead of competition, thinking very differently about the mechanisms that bind organisations and partners together, whether that's through lead provider models or binding contractual integration agreements, or the emergence of different types of partnership arrangements. I think across GM that will start to emerge in a slightly different way in different places, but will all be consistent in this new era as we move forward. I think we can't lose sight, though, is that what we ought to be really pushing forward in Oldham is a networked neighbourhood model of delivery, where we bring forward the full gamut of public services alongside health and care in a single model where we share information, we tackle the problems, and we focus on the wider determinants, not just health care, but things like health and care, mental health, housing, schools, drugs and alcohol, and a whole variety of other issues. You know, I'm able to quite easily say how many people are turning up at the hospital every day with respiratory disease, and I think I'm quite easily able to say how we're treating those people medically. But what a difference it would make if we had a different conversation about the root causes of that respiratory problem, because a lot of it is about environment, housing, stock, and we could under a system-based budget choose to start to think very differently about how we deploy our resources to achieve better outcomes. And I think that has to be one of the benefits of now starting to embark on a journey of this type of nature. For me, that then has implications, and to crystallise the work that I think is required between January and the end of March, I think we do have to get into a proper set of ways of working that describe the new governance options, the function of membership of a local systems board, the delegation framework that will be required for that, how the funding flows from Greater Manchester into Oldham, then around Oldham across the partners. What is the clinical professional leadership model and framework? I purposely chose to not describe political, because this is not about changing the political leadership model. This is about bringing the clinical professional leadership model into and aligned with the political leadership framework that currently exists, and maximise the way that we've been working. And indeed, we have a good start in Oldham. We have a joint commissioning partnership board that I think functions reasonably well, but I think everybody who sits around that table fully understands that we could do so much more if we had so much power and scope to make different types of decisions. And I think this is a chance for us to start really thinking about how we enable that. I think we are going to have to really tackle the conversation about what do we commission at what level. So there are definitely some services that I think will be far better served if we commission them once across the Greater Manchester footprint, but there are other services that absolutely need to remain locally focused, locally commissioned, locally designed. And notwithstanding that, I mentioned at the very top of the conversation about the need to not lose sight of what we're entering into is very much an organisational change process, particularly on the CCG side, and with that comes people and HR implications. We need to deal with them appropriately and responsibly, and make sure that we follow the right kind of procedures and processes in place to get us to the end outcome. So we have a tall order in front of us and an awful lot of work to get done over the next 14 months to take us to the end of this financial year into a new one. And myself and the team don't underestimate the scale of that challenge, but I definitely think this is a once-in-a-lifetime opportunity, I think, to really start to change the 72-year-old model of how the NHS works. And for those people that are probably a lot closer to me than others, you'll know that's code for me saying that we can't carry on with a NHS model that is wholly focused around acute hospitals. We need to find a way of starting to focus an NHS model in a place where 90% of the activity takes place outside of the hospital walls, and making sure that that works effectively and appropriately. And that I think is a very exciting prospect as we go. We're at that rather interesting phase of birthing a project where it's all about the systems, the process, the governance, all the very boring bits. But I certainly look forward to the benefits that will come from redesigning pathways and start to make services more accessible and different for patients. I don't know if Councillor Stretton left or stayed on the call.
I'm afraid we lost Councillor Stretton, I'm afraid, about 5 minutes ago.
I noticed.
I'm wondering if Majid, as one of the vice chairs, would take over, please. Take over in the chair.
Yeah, sure, that's not.
I noticed Councillor Chow hands up, Majid.
Yeah, okay. Thanks for that presentation, Mike. And just before I bring Councillor Chow, all throughout today's session, we heard countless times deprivation, inequality, disproportionality, etc. And it's absolutely right and the right thing to do to bring everybody together and sort of tackle it as a system rather than try and tackle those issues as individual organisations, because we're not going to make the difference that is required. So thanks for that. And Councillor Chauhan, over to you.
It's always a good sign when you have a list of things in your mind and someone else has said all those things. So thanks, Mike. You probably have covered more or less everything I wanted to say. But I think I just wanted, from wider system point of view, from Oldham point of view, for people to realize it's a great opportunity for us to do something completely different and set our stall, which we never as such had an opportunity in the past to do it. B, it's not an easy journey, it's quite a difficult journey. And C, that we're going to have loads of challenges to try to get to that stage. So I'm quite pleased that our political leadership, our executive leadership, which is Mike and others, and our clinical leadership, Dr. Patterson, who is around here as well, we all been one voice on GM level of saying what do we want from Oldham, for Oldham, and to not compromise that. And some of those things which Mike highlighted is saying, yeah, there are things which can be done on the GM level, but we don't want to give up the control. And it needs to be a real devolution. So that real devolution needs to come to not only to Oldham, but from Oldham to localities, further on PCN levels, on cluster level, on neighborhood level, because we appreciate and understand the uniqueness of each cluster, even or each community in Oldham, and they have their own specific needs which needs to be catered, and hopefully this approach will help us to do it. But also what's really important is so we have some very good key clinical leadership to make sure that in the process of merging of all the CCGs and things, we don't lose that leadership. Actually, we expand on that leadership. So is how do we ensure, and we've been having loads of conversation, me and John and Mike and others, saying what is that local system we will have to retain that clinical leadership in place and actually expand on that and bring more into that, like district nurses and health visitors and midwives, so that clinical leadership becomes a true clinical leadership. I'm not saying that it's not at the moment, but it needs to be a bit more than me as a GP, and it needs to be a bit wider. I think it's been my personal interest, for all the right reasons Mike mentioned, and our political sort of like view of this administration, that it needs to be community based, not the acute focused, because we want to get to that stage where no one hopefully one day will need acute services at all, because we will work on proactive care, not reactive care, have a better healthy population rather than unwell or unhealthy population who needs a lot of acute cares. We had a meeting this morning, and me, Katrina and Rebecca, and we were talking about our leisure services, and we said, how do we include our leisure services into each locality as well and make them guardian of activity in that particular locality? And that's a model we want to get to, where say, here we go, that's your bait. It's being that proactive and prevention. And I think, sorry, Mike, I'm just stealing your phrase, because I could not articulate a few months ago when I was just trying to explain you, and you gave me 3 words. It's saying how on this locality we design, commission, and hold things accountable as well. and making sure that we have a proper democratic accountability. So I can't forget those 3 words, because I struggled and stuttered for an hour with you trying to explain what I want, and you gave me 3 words, and then I just like I've written it down. So, and also, Mike, say personal thank you to you for it's not an easy journey, it's hard work, and I know you, John, and other team. It's list goes on. It's a very long list, but thank you to all you and your teams to go through this difficult change management, pulling everything together. Thank you.
I think Councillor Stretton is back in the meeting.
I'm back, yes. That was quite frustrating, sitting looking at it, telling me it was updating and not to switch my computer off.
I thought Councillor Stratton heard 100 slides and she thought, I better switch it off now.
No, I'd already told people at the beginning of the meeting that I'd got a warning that it was going to kick me out. So anyway, I am back. I've got one more hand up. I've got Katrina.
Thank you, and yeah, just first of all, thank you to Mike for setting out that vision and the plan so clearly. I think it's really helpful. It feels like it's kind of the culmination of lots of work that's been happening over a period of time. And I think we've got a real opportunity now to focus on our population and on health inequalities and on place. Rather than sort of going back to seeing everything through the lens of services, which I think is historically where we've always been, isn't it? And is where people naturally gravitate to. But you know, that's not happened by accident, has it? That has been about a lot of the groundwork that's been done over the last year or so with the work on the population health system development with the King's Fund. I think as well, you know, we're in line with the GM direct travel here. That I know previously we had the sort of GM health and social care plan and then a separate population health plan. And I think everyone has recognised that we want the GM health and care plan to be the population health plan. And, you know, I know that's where we are in Oldham as well, but we are in a good place to be at the forefront of that.
I'll just come back on that, Councillor Stratt. It's a bit of a personal story, really, but one I hope helps. You know, I started my career in local government and then spent a little bit of time in the commercial sector before I came back into the health service. And I've spent a lot of time working in big teaching hospitals, generally as a professional marketeer with my commercial background. And first came to Greater Manchester to work in Trafford. And that was 12 years ago, a little bit more than 12 years ago, actually. And I absolutely think that since 2012, and you'll all know what changes came in 2012, I think one of the biggest regrets that the health service should have is its ridiculous ability to disconnect the public health function from mainstream healthcare, because the minute that happened is the minute that the focus around health inequalities and communities disappeared in the NHS. This is a real chance to get that back. A real chance, and a real chance to join the conversation up between what happens in public health and public protection, what happens in leisure, what happens in housing versus what happens in the NHS. And I think, you know, it will be very easy for us to sit back, wither on the vine and go with the flow. I guarantee you going with the flow will end up in a hospital, because it always does. And history tells us that it always does. And the brave leadership of people like Councillor Chauhan sat in meetings relentlessly talking about what's needed for Oldham, relentlessly talking about the deprivation, the poverty and the inequality, and people like John, and to an extent myself, standing in front of people, you know, like we have done this morning, saying actually we need the AstraZeneca vaccine because it's more suitable and convenient to tackle inequalities and deprivation in our community. We need to use opportunities like this to just remain absolutely focused on not just doing the straightforward modernisation change, but trying to right some of the wrongs that have taken place over a long period of time and get them back on track. I can't remember the last time Katrina has probably been excited by a conversation about, you know, not just closing the gap but narrowing the gap as well. And I remember the charts 12 years ago where we're constantly looking at how that was working. And for me, if we achieve anything, we start to get a proper conversation back on health inequalities, it will be a major achievement going forward and it will serve our population well.
Thanks for that. Are we happy to note the report? got anybody saying no, so I'll take that as assent. Okay then, thank you everybody for attending the meeting. The only item on the agenda now is item 11, which is the date and time of the next meeting, which is Tuesday, the 23rd of March at 2 p.m. And apologies for my having to leave when my computer rebooted. Thanks everybody.
Thanks, Chair.